All right, let's talk about nitroglycerin. Nitroglycerin is classified both as a nitrate as well as an anti-anginal medication. It is a potent, smooth muscle relaxant used in the treatment of angina. Now, understand in particular, the smooth muscle that it is trying to relax is going to be the smooth muscle of the arterial system. When it relaxes, it allows the arteries to dilate, bringing more, hopefully, oxygenated blood into the cardiac tissue. Now, it reduces cardiac work and to a lesser degree dilates the coronary arteries. And so it increases the blood flow into the heart, makes it easier for the oxygen demand of the heart to be met. As a result, this comes about and results in an increased coronary blood flow and improved perfusion of the ischemic myocardium, ischemia relating to oxygen deprived. Relief of ischemia now causes a reduction and potentially even alleviation of the chest pain. Pain relief following nitroglycerin administration usually happens within about 1 to 2 minutes, and therapeutic effects of the total elimination of the pain, if it's going to eliminate the pain, can be seen for as long as 30 minutes afterwards. Like we said, nitroglycerin also causes vasodilation, which drops our preload. Now, just by way of remembrance or review, preload refers to the volume, the amount of blood that is being sent back to the heart. When we have decreased preload, it leads to decreased ventricular filling, which also results in reduced oxygen demand. The other thing about preload that you need to remember, and this is true not just for cardiology, but all across the board, is that when we reduce preload, we reduce cardiac output, and that may be what we want to do sometimes. As far as its onset, as I said, when we are giving it, we're going to give it sublingual, underneath the tongue. Onset happens at least as far as some of the effects of nitroglycerin is very rapid, because it'll happen in about 1 to 3 minutes. Keep in mind that underneath the tongue, it's really, really vascular, and those vessels lie very, very close to the surface of the mucosal membrane. As a result, as it dissolves, or if you're using a spray, it gets picked up really, really quickly. You can expect to see the peak effects with a maximum pain relief within about 5 to 10 minutes, with that relief lasting for about 20 to 30 minutes. The half-life of nitro is going to be 1 to 4 minutes, meaning that, again, like we see up here as far as the duration, we're generally going to see a diminishing of effects and side effects within about 20 minutes as it gets out of the body's heart system. The indications that we're utilizing nitroglycerin for will be 2. We'll talk about both of them when we get into these specific etiologies as chest pain as well as congestive heart failure. Understand that the new nomenclature for congestive heart failure is just simply to call it heart failure now, but I've used congestive heart failure for so very long, I'm just used to it, and that's what I see. Some contraindications is if we have a blood pressure of less than 90, we're going to be really, really leery about administering nitroglycerin. I would tell you, you may still give it, but I wouldn't give it to a patient that has a blood pressure of less than 90 unless I did a consult with med control by phone or by radio. The other situation in which that we're going to have a contraindication, and I've never come across this situation, is that if you've got a patient that's got increased intracranial pressure, from either, say, like a potential tumor or more common from head injury. Because it causes vasodilation, it increases the pressure within the brain, and you can make that intracranial pressure even worse. Now, if your patient has a long-term history of taking nitro, they may develop a tolerance for it, which might require you to increase the dose or maybe to reduce the time frame between the doses that you're going to give. This is, again, one of the reasons why when you're getting your history on from your patient, you want to find out, do they take nitro? Yes. Well, how often do you take it, and how many times over the course of the day do you take it? Headache is going to be the most common side effect of nitro and results, like I said a minute ago, because of the vasodilation of the cerebral vasculature, primarily the arterial system of the brain. Now, nitroglycerin is an unstable medicine, and it deteriorates really quickly once the bottle is opened. When a bottle of nitroglycerin is opened the first time, you should put on the bottle the date that it is opened so that you can know if it's beyond probably 90 to 120 days, it's probably not going to be nearly as effective. It should also be protected from light. It will deactivate in both light and heat. And this is particularly true for the tablets. It will cause the tablets to disintegrate rather quickly when they're exposed to heat. Blood pressure and other vital signs should be monitored both before, during, and after nitroglycerin administration. Some of your side effects that you're looking at are things such as headache, dizziness, tachycardia. It can cause your blood pressure to drop, as we've already talked about. It can cause orthostasis, which is a blood pressure that is lower when you're standing up as opposed to when you're sitting or lying. Don't give your patient nitroglycerin while they're standing. For some patients, it can cause such a rapid drop in the blood pressure that they may start out standing, but now you got a trauma because they fall into the floor. It can result in a dry mouth, and like most other medicines, it can cause nausea and vomiting. If your patient has had alcohol, you can have, again, that synergistic effect of between the alcohol and the nitroglycerin that can intensify the hypotension. So again, be leery of, or not leery, but be wary of administering nitroglycerin to patients who have recently consumed or drank alcohol. Not telling you you're not going to give it, but again, remember, you're going to treat what's going to kill your patient first. Other things that can come about is that it can cause your patient to have orthostatic hypotension when used with patients that are taking beta blockers because their blood pressure is already going to be low. Typically, what happens when our blood pressure drops as a result of taking nitroglycerin is the heart rate will kick up to compensate. If your patient's taking a beta blocker, that's probably not going to happen. Your dosage for nitroglycerin is to give one tablet or one spray, which will be 0.4 milligrams, and it's going to be administered sublingually for anginal type of chest pain. And we're typically always going to start, even if we feel fairly certain that this is not angina, but coming from a STEMI or an MI, we're still going to start with a nitroglycerin and work our way up. Now, this dose can be repeated in 3 to 5 minutes as required. Now, typically, we're not going to give more than 3 tablets in the pre-hospital setting. And again, especially for patients that have never taken nitroglycerin, if you're giving them a tablet, make sure that they don't swallow it. It'll be inactivated or deactivated in the acid of the stomach. Tell them to let it settle under their tongue, just let it dissolve a little bit. They may feel just a slight, very, very slight burning sensation as it begins to dissolve. Again, make sure your patient does not swallow this medicine because it will not work. IV nitroglycerin is used in the emergency department and the intensive care units, but the sublingual route is adequate for most pre-hospital situations. It's rare that we would utilize IV nitroglycerin, but we will cover IV nitroglycerin a little bit later on in the semester. Nitro or nitroglycerin is also available in patches as well as in ointment form for transdermal or through the skin administration. That is typically going to be for patients that are on long-term use of nitroglycerin. All right, so let's talk about more pain relief. And in this one, we're going to talk about morphine sulfate. Morphine is an old drug. It's been around for a very long time. It's classified as a narcotic analgesic. It's also a central nervous system depressant that acts on the opioid receptors in the brain. And the nice thing about morphine is that it provides both analgesia, pain relief, as well as sedation. It reduces the patient's anxiety. It increases peripheral venous capacitance and decreases venous return. So basically what that means is when we give morphine, it decreases the myocardial oxygen demand. So it makes more effective the oxygenated blood that is coming to the heart because it is reducing, in essence, preload. This action is due to both the decreased systemic vascular resistance as well as the sedative effects of the medicine. So if we can reduce the anxiety of the patient, we're also going to reduce the action of the sympathetic nervous system, thus leading into a decrease in workload on the heart. Patient apprehension and fear can really increase the amount of oxygen demand that the heart has, and in some cases can actually increase the size of the myocardial infarction. When this extension happens, this is not going to be good for your patient. As far as the pharmacokinetics, generally, if we're going to give it IV, we don't always give it IV, it's going to start to work really quickly. Again, it's going to be dose dependent. If we give it IM, it's typically going to take about 15 to 30 minutes, depending upon how well the patient's vascular flow is. What we're going to see is our peak effects in about 20 minutes and up to an hour if we're going to administer it IM. Now, it's a good lasting drug. It'll last somewhere between 2 to 7 hours, and it's really kind of weird in the fact that, again, much of this is dose dependent. The half-life can be anywhere from 1 to 7 hours, so the effects and the side effects can be in there for quite a long time. And we'll talk a little bit more about why this might be a bad thing, particularly when we talk about the administration of fentanyl that is beginning to become more favored for patients that are having cardiac pain. Morphine is used for any kind of pain, not only just myocardial pain, but it can be also utilized for patients with kidney stones or fractures, severe extremity trauma. It's a really good drug to use for that. It can also be utilized as far as in heart failure. Its use in pulmonary edema and heart failure has been limited recently in favor of more vasoactive agents such as nitroglycerin, which causes venous pooling, and ACE inhibitors. Now, ACE stands for angiotensin converting enzyme inhibitors. So angiotensin is a chemical that causes vasoconstriction, causes the blood pressure to go up. It can lead into, particularly when a patient has chronic hypertension, leads into congestive heart failure. When we give an ACE inhibitor, and you may be giving some ACE inhibitors, as we'll talk a little later on, this will help to bring the patient's blood pressure down, and it causes more venous pooling in the presence of heart failure, allowing more of the fluid that is within the lungs to migrate out. Morphine should not be used in patients that are volume depleted or really badly hypotensive because of the hemodynamic effects described earlier. Remember, if we give morphine, two things that we're looking at here is, number one, it will drop your blood pressure, okay? And number two, is because it's a narcotic, it can have a negative impact on your patient's respiratory status. Again, if your patient is already hypotensive, we don't want to make them worse. Morphine should also not be given to any patient that has hypersensitivity to the medication, and this is going to be true for all your medicines, or if they have any type of a head injury. We want to be very, very leery about giving a sedative to those types of patients. Now, morphine is a narcotic derivative of opium. It does have a high tendency for addiction and abuse, and it's classified as a Schedule II medication, which basically means that it is beneficial, but it can become addictive. The medication that you're going to give to your patient will in no way, shape, or form cause them to become an addict. You're just not going to give that much medicine. Now, as a result of that, there's special considerations involved in the handling of the medicine. As we said earlier, morphine can cause severe respiratory depression in high doses and if it is given rapidly. This is especially true if your patient already has some type of a respiratory impairment going on, if they're in severe respiratory distress, or if they're bordering or moving over into respiratory failure. Anytime that you give a narcotic, you should have Narcan readily available whenever you give it. This is true for morphine. You don't have to get your Narcan out. You don't have to open it up. Just know where it is so that you can get to it when you need it. Morphine can cause nausea and vomiting, as can all drugs. It can especially cause abdominal cramps if it's given too quickly. Because of its sedative effects and its action on the opioid receptors of the brain, it can cause the patient to have blurred vision, and that blurred vision is made worse by the constricted pupils. Leads into your patient having an altered mental status and respiratory depression. So you want to be really careful about that. When we are giving morphine, the central nervous system depression associated with morphine can be enhanced when it's given with antihistamines such as Benadryl and some antiemetics such as some of the medicines, antiemetics that we typically don't give a lot anymore. Other sedatives, hypnotics, barbiturates, or alcohol. And we really want to be very, very careful if we're giving morphine in the presence of a patient that's having alcohol on board. An initial dose in the range of 2 to 10 milligrams IV is standard. Here's what I would tell you to do is that I would tell you to draw up your morphine and give it in 2 milligram doses. Morphine is a drug that you can always give more, but once you've got it in, pretty much the only way that you can stop its action is by the administration of Narcan. If we give Narcan and we wipe out morphine, guess what? Our patient's chest pain comes back and comes back pretty quickly, which causes severe anxiety for our patient and raises the oxygen demand. Now, this dose can be augmented with additional doses of 2 milligrams every few minutes and can be continued until the pain is relieved or until your patient begins to show signs of respiratory depression. Now, generally what you're going to do is if you're wanting to get similar effects from IM administration, you're usually going to need to give anywhere between 5 to 15 milligrams based on your patient's weight. There's no hard, fast type of formula that will lead that into knowing how much to give for your patient. But the larger the patient, the greater the doses that you're going to be. However, morphine is routinely given IV in emergency medicine and sometimes is given with an antiemetic such as Phenergan to help prevent the nausea and vomiting that often accompanies morphine administration. Now understand, Phenergan is an antiemetic that we don't use a lot anymore, primarily because we have Zofran, which is much more effective and does not have the sedating effects of Phenergan. When morphine and Phenergan are given together, again, you have that synergistic effect. Synergism meaning the end is greater than if we gave each individual drug. So morphine, Phenergan work together to cause a greater pain relief, but it will also cause greater as far as the sedative effect of the medicine when you administer it.